Good evening, everybody. I think already we are nearly half a century of people into this session. So we'll just wait for maybe another 60 seconds to 90 seconds before we start. It's a pleasure and privilege to have everybody in. And I can already see that there are quite a few of the people for whom it is intended for. Essentially, it's all started with the students of Apollo Gleneagles Hospitals, Kolkata, the DNB trainees at Apollo. But yeah, I think over the last couple of months, it has expanded, and we find that from the friends of the students that we have, it has reached to a lot more people. So I think we will quickly run through this, which is preoperative pulmonary evaluation and optimization. Uh, we went through the facets through which you can go through it. So what we will try and do is run through this. So you see, the reason you need to evaluate for risks and figure out whether this person is going to safely go through this journey of surgery is to figure, because of this high perioperative morbidity and mortality coming from respiratory complications, which is why we need to evaluate. What we will try and do over, I know it is already 9 o'clock, maybe we should finish within 9:30, max 9:40, is define postoperative pulmonary complications, understand the pertinent anesthetic physiology, identification of patient and procedure-related risk factors, and the role of preoperative pulmonary testing, which has mainly been dealt with by Dr. Polash. Strategies for optimization, which will also be kind of an overlap with the third point, which is identification of the risk factors, and that is those risk factors, how it can be optimized. Okay, there's been a huge kind of a difference about what exactly is the amount of pulmonary complication. Some people have been over enthusiastic saying that up to 70%, but this is because of a lack of a proper definition. The definition which has been given, I think this is one of the best definition to go through by Donohue, that what is postoperative pulmonary complication is a pulmonary abnormality which is appearing in the postoperative period, which produces identifiable disease. You can identify, or a dysfunction in the pathophysiology, which is clinically significant and is definitely adversing the clinical course. So you identified a pulmonary problem, clinically significant, affecting a clinical course. This is the definition. And going by this definition, what are the things that causes this are just a very wide spectrum term, like an atelectasis, infections like bronchitis, pneumonia, respiratory failure, which is defined by necessity of mechanical ventilation for more than 48 hours post-surgery, or an unplanned reintubation, episodes of hypoxemia, and exacerbation of the underlying disease, like a patient with COPD or asthma as an exacerbation. So this is what is defined as post-operative pulmonary complication. And when you go by this definition, and this is the systematic review done by Statna from Boston and for the American College of Physicians, and they figured out that if you use those defining criteria, these are around 6.8% across all types of surgeries. And with one pulmonary complication, there is an associated higher rate of mortality, ICU admission, and length of stay, which is why pulmonary complication, we kind of at times do not think about pulmonary complications, but pulmonary complications are, to me, as important as a cardiovascular complication, because you figure out the rates of cardiovascular complications are lower than what is being quoted in this slide. And that is essentially why you need to have a very good pulmonary evaluation, risk stratification, and necessarily, if necessary, optimization prior to surgery. We will focus on non-thoracic surgery for the next half an hour. All right. Okay. So if we can set up the poll questions now. So if you what you essentially what we will try and do is, if you look, we will give you these polls. Jyoti, can you set up the polls, please?
Yes, sir.
Okay. So you will have your polling things with you, the participant, whoever part of this. So we can start the poll. Which of the following is not a patient-related risk factor? I'll paraphrase it is, which of the following is not a very significant patient-related risk factor for the development of postoperative pulmonary complications? Okay, if you have voted, we will close the polling in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. I think most of you would have voted. You can end the poll and we will go to the next poll. Okay, the next poll. We will come back. So let's just look at which pulmonary physiological change is not true during anesthesia and surgery. Vital capacity reduced by 50 to 60%, closing volume reduced by about 30%. Reductions in lung volumes are generally not seen with surgery on the extremities. Diaphragmatic dysfunction plays an important role in the changes. So please, please feel free, and this is complete anonymity. There is no marking on any one of you. So please feel free to put your votes on this. What we will do is we will, at the end of it, we will come back to these polling questions and then kind of sum up the entire thing. Okay, can we go to the next poll, end this poll and go to the next poll? We need to go to the next poll. And the next poll is you have to choose between these two. A 56-year-old male with a history of COPD is posted for a planned laparoscopic cholecystectomy. Okay, the person has mild dyspnea on exertion when you are seeing the person, as purulent sputum production tells you, and when you auscultate, there is an audible wheeze. What will you do? You will increase the dose of the bronchodilators and steroids, start antibiotics, admit, proceed for surgery, or will you cancel the elective surgery, send the person for a pulmonology consult, wait for the resolution of sputum and disappearance of wheeze? So please let us know what you feel like doing. Again, we will come back to all these polling things at the end, and that the reason why you are taking it through. So can we end the poll in 5, 4, 3, 2, and 1 and go to the next poll? Okay, so this is a 65-year-old female posted for thyroidectomy. She is a known asthmatic for more than 15 years. She's on inhaled steroids on a regular basis, occasional bronchodilators inhaled, has absolutely no functional impairment. She does her routine work. She is able to climb 2 flights of stairs. She is not breathless. She talks to you perfect. All right. Our other routine hematology biochemistry is normal. What would your plan for this lady be? whether it would be just inhale nebulization 30 minutes prior to surgery and proceed, or would you ask for a PFT and an ABG? If normal, then proceed. Start her on oral steroids and antibiotics and wait for 5 days and then take her up for thyroidectomy? Or would you refer her to a pulmonologist and then take her up, proceed subject to the clearance from the pulmonology consultant? What would you do on this scenario? So just feel free to put your vote into whatever you feel is the most appropriate for this. And again, if you are done your voting, I think most of you would have done your voting by this time. We'll close the voting in 5, 4, 3, 2, 1. Okay, and we'll go to the last poll. Jyoti, if you can reset and put that last poll. So this is a 66-year-old male with type 2 diabetes, hypertensive, and hypothyroid. All of them are reasonably well controlled and is posted for hemicolectomy for CA colon. He gives history of difficult airway during a previous gallbladder surgery, which happened some 6 years back. Hemoglobin is 10.2, glycosylated hemoglobin is 5.9. The routine biochemistry and hematology otherwise are normal. So you want to do a further evaluation. So if you have to do one further evaluation, which will you choose? Would it be stop bank questionnaire? Would it be pulmonary function test? Would you do a CPET, or would you do a polysomnography? So which is the thing that you would want to do in this 66-year-old? And again, as I said, we will come back to all these at the end, provided you are awake when we finish. Okay, I think we can close the poll in 5, 4, 3, 2, 1. Okay, so we'll come back to the polls at the very end. Till then, again, as I said, just keep chatting, and we'll go through this. So we'll first deal about perioperative pulmonary physiology. If you look at the perioperative pulmonary physiology, it is essentially the development of postoperative complications are extension of the derangement of the pulmonary physiology, which is mostly of the restrictive type, like reduced lung volumes, diaphragmatic dysfunction takes place, reduction of the FRC, microatelectasis, loss of sighing breaths, and depression of the respiratory drive, inhibition of cough, and impairment of mucociliary clearance. And the last two essentially is because more not essentially mechanical causes, but due to the effect of drugs during the anesthetic course. Reduced lung volume, reduction of FRC typically happens more in thoracic and upper abdominal surgeries. The vital capacity reduces by 50 to 60%. The FRC reduces by 30%. And this reduction in lung volume, FRC, microatelectasis, loss of sighing breaths is mainly due to diaphragmatic dysfunction. Now, whether it is compression or whether this is classic paralysis or the abdominal contents going up due to the positioning or the institution of positive pressure ventilation, all these things. Along with this, postoperative pain, which is extension into the postoperative period, also could be a reason for all these which are mentioned in the left-hand side. FRC, we figured out, will go lower than the closing volumes. Once FRC goes lower than the closing volumes, you will have leads to microatelectasis, and atelectasis will contribute to the development of pneumonia and the VQ mismatching.